Hi, everyone. We'll just wait a couple of minutes until everyone gets logged in. Okay, we might get started. So hello, everyone, and welcome this afternoon to another Lymphoma Australia patient educational webinar. So I'm Lisa. I'm one of the nurses at Lymphoma Australia. You may often see me on these educational webinars. You may chat to me on the phone, or you even sometimes receive emails from me. So it's nice to see everyone today. I'd like to begin by acknowledging the traditional owners of the land. I'd also like to pay my respects to elders past and present. I'll start with some quick housekeeping. Please, if you have any questions throughout the webinar, put them into the Q&A function at the bottom of your screen. We have a small amount of time at the end and we will hope to answer some of them. There is also a chat function, but this will not be monitored for questions. So please use the Q&A section if you do have a question. If you miss anything today, please don't stress. The webinar will be uploaded to YouTube within the next week, and a link will also be sent to you. We do have a few webinars planned over the year on different subtypes, as well as supporting families, social and welfare considerations. We are planning a patient summit, hopefully in person, possibly in Sydney, in September around World Lymphoma Awareness Day. So watch out for that. And for anyone that isn't aware, we do hold regular online support groups via Zoom. We have one this Friday at 11 a.m. Queensland time, and also one specifically for watch and wait people next month. So watch out for our emails, and you can also visit our events calendar on our website. So you can, I'll pop that link in the chat for anyone who's interested to go and have a look. Okay, so on to the webinar. Today, we are so very fortunate to have Dr. Nicole Wong presenting on follicular lymphoma for us. So Nicole Wong is a clinical and laboratory haematologist and the director of clinical research unit at Concord Sorry, I mumble every time I say that. Sorry, Nicole. Can't say that. Concord General Hospital. Nicole completed her haematology training at the University of New South Wales in Sydney, followed by a fellowship at the Peter MacCallum Cancer Institute in Melbourne. She has an interest in indolent lymphomas, including follicular lymphoma. So we thank you, Dr. Nicole, for presenting for us today. And we have quite a number of people here to listen to what you have to say. So thank you.
Thank you so much, Lisa. It's a pleasure to be with you today, and I just noticed that someone had commented that the volume was a bit low, and so please, if you having trouble, just send a message through, and I'll try and make sure I speak really clearly through my headset as well. So in just a second, I'm going to start sharing my slides, and then I'd like to encourage you all to think of some questions for me along the way. And oftentimes as I'm presenting, I might not be able to see them all pop up, but Lisa and Erica will help me. If there's a question that you want that Lisa or Erica thinks that would be good to just to interrupt with, that's very fine with me. Otherwise, obviously, I'll go through all the questions towards the end. So welcome, everyone. I'm really conscious that there may be quite a mix of people listening to the webinar. Some of you who may have listened to others before and been to other patient information sessions when we have done them face-to-face in the old days, and some of you that may be new to these information sessions. I always encourage my patients to go and look up what information sessions are available and to listen to the pre-recorded ones given by some of my dear colleagues. So it's great, it's so lovely to be part of one. So I work at Concord Hospital here in Sydney, and we have a big and busy clinical research unit where we run a number of clinical trials as well. Today we're going to focus on follicular lymphoma. It's the second most common non-Hodgkin lymphoma. And so one in which there's a large body of knowledge and ongoing research, because there are still many unsolved challenges that we have in follicular lymphoma. But certainly being the second largest non-Hodgkin lymphoma gives us some reassurance about the quality of the research that's come and brought us to this point and the research into the future. I'll start with some of the symptoms of lymphoma, just so that when I refer to them later on, we're understanding the same things. Some people with follicular lymphoma will present with enlarged lymph nodes that we often say in the textbook are usually painless. But of course, if a lymph node enlarges a bit faster or in a sensitive location, then the stretch of the lymph node capsule can absolutely become uncomfortable, or may press on another structure in the body and causing some pain as well. But generally, the enlarged lymph nodes are not painful. The B symptoms that we'll refer to later on in the talk are those of weight loss, night sweats, unexplained fever, and loss of appetite. And then some of the abnormal blood tests that can lead to a diagnosis of lymphoma can be anemia or low red blood cells, low platelets, or sometimes a negative effect on underlying organs such as finding of kidney failure or a high calcium level in the blood. And in our diagnosis of follicular lymphoma, we ask our patients to undergo a number of different tests. And I think sometimes this is an overwhelming part of the step in patients' first diagnosis with follicular lymphoma. They may have gone from someone who may have had very little involvement with doctors before, and then are asked to have blood tests, CT scan, a biopsy, a PET scan, possibly a bone marrow biopsy, and maybe other tests as well. I hope that there may be some questions about the diagnostic tests that you have had some experience with, because sometimes we as doctors skip past this and just concentrate on the treatment. But we do know that is the first sort of introduction that patients have to having follicular lymphoma, is being sent on this round of tests. A key part of diagnosing follicular lymphoma is to have an adequate biopsy so that we can come to the correct diagnosis of follicular lymphoma and then of the subtype. By and large, our preferred biopsy for diagnosis is to do an excision or a surgical biopsy on the left there, where an incision is made in the skin, and an area of usually a lymph node or the abnormal lump is removed. It may not be the whole lump. Sometimes the surgeon may take a section of the lymph node and leave the rest of the lymph node in there. And the patients will often ask, well, can I have that lymph node removed? Can that be part of the treatment, or can that in fact be the entire treatment? But generally we see surgery as a diagnosis rather than the cure, in a large number of cases, follicular lymphoma occurs in more than one location, and so surgery is not usually part of the treatment as such. Sometimes the surgeon will want to take a segment of the lymph node rather than the whole lymph node, because there may be other structures like nerves or blood vessels that might be in danger if the surgeon takes the entire lymph node out. So it's really good to have a discussion with your haematologist and the surgeon, if you're recommended to have a surgical biopsy, about what is going to be done. Surgery, is the whole lymph node going to be taken out or just a part? And sometimes the surgeon doesn't know what they're going to do exactly during the operation, because it depends on what they find when they make that first cut, but they should give you an idea of what the different possibilities are. So then when we look at that specimen under the microscope, we can see those, we can see these circular patterns in in the lymph node, and these are the follicles of the lymph node, and that's where follicular lymphoma gets its name. All lymph nodes have a normal follicle, but in follicular lymphoma, these follicles expand and multiply. That pattern is really important to help us make the diagnosis of follicular lymphoma. So hopefully you can see why taking a larger sample can be really important in making the diagnosis. But alternatively, sometimes we cannot take a surgical sample and the lymph node's too deep, and so we take a core biopsy, and that's when we pass a needle into the center of the lymph node or the mass and take a sample of tissue out, and we get these skinny cores to look under the microscope. Fortunately, we can see sometimes where the residual of a follicle is, and the pathologist can still tell us of the diagnosis. But occasionally, if you've had a needle biopsy, you may be informed that that sample that was taken was not suitable or not possible to make a diagnosis from, and a second biopsy may be needed. The next picture here is of a PET scan, and really nearly all patients with a diagnosis of lymphoma will be asked to have a PET scan to understand the stage of lymphoma. And as many of you have seen, a PET scan shows the uptake of glucose that's attached to a radiolabeled marker, and that glucose is taken up preferentially by the lymphoma cells. That's not to say that the lymphoma cells like to feed on glucose, and that's not how lymphoma cells grow, but lymphoma cells do use up a lot of energy, and when they're growing, and then so they do suck that glucose into their cells, and then we are able to see where the lymphoma is. So the big black spot in the skull is a normal brain, and the brain also sucks up a lot of energy, and so it's dark in the normal situation. And then we get rid of that glucose marker in our bladder, so that black spot at the bottom is the normal bladder. The heart takes up a lot of glucose as well, so you'll usually see normal dark area in the chest, which is the normal heart. But then all these other dark areas are areas of lymphoma involvement, lymph nodes up in the neck and the chest, and then also further down in the abdomen. So compared with the standard CT scan on the left that shows us the structure of and the shape and the outline of a lymphoma mass in the middle of the belly here, the PET scan shows us the activity of the lymphoma that most of you know well. The brighter or the more intense the color of on the PET scan, can sometimes relate to the rapidity of growth of the lymphoma. So I'll move past these images here and just remind us that when we talk about lymphoma staging, there are 4 stages of lymphoma. You may have heard us in the clinic group the stages together because the treatment is very much similar for stages 1 and 2 together compared with stages 3 and 4. Sometimes the treatment is quite similar through from stages 2, 3, and 4. And so we do have these 4 designations, but we don't have a separate treatment for each 4 of the 4 stages necessarily. The follicular lymphoma most commonly presents in stage 3, and that's because as a slow growing lymphoma, it often doesn't cause any symptoms until it's had that opportunity to spread, and the lymphoma cells do have this avenue to travel between lymph nodes through the lymphatic circulation and sometimes through the bloodstream as well. So it's not automatically a negative thing that to be in stage 3, and that's something certainly that does initially cause some of my patients some anxiety until we explain that is probably the more common situation for lymphoma as compared with other cancers where one might have more concern about having a stage 3 cancer. I'm sorry, I've drawn my own picture of a lymphoma cell and the different markers, and because whenever I look up a picture of what lymphoma cells are like online, they're so overcomplicated. But I want to show you this cartoon of a lymphoma cell so that I can explain where the different targeted treatments are acting. So this is the outside of one lymphoma cell, and this is the dark blue line is the nucleus of the lymphoma cell, and inside is the DNA, the coding of the lymphoma cell, and on the outside of the lymphoma cell are these flags of proteins, and they're typical of really every follicular lymphoma cell. We're called a CD and then a number. Most of you will know CD20 was the target of our first targeted therapy, rituximab. But then we also have CD19, CD79B, CD47. And these have now in later years become targets for some of our more novel therapies. Inside the cell, you've then also got other targets. These are processes within the cell that are really overactive in a lymphoma cell, more active. These processes are going on inside all of our cells, but they're in hyperdrive in lymphoma cells. And so these are the areas and the processes where the lymphoma cells are susceptible to being damaged. Lymphoma cells are growing and dividing. That's why they cause problems. And to grow and divide, they have to replicate their DNA. And so that's where the traditional chemotherapy has targeted disrupting the DNA dividing. There are other pathways inside lymphoma cells like B cell receptors and BTK pathways and other elements that we try to target with our targeted therapies. So I'll come back to this cartoon later. I'm just going to get sort of the stage 1 and 2 lymphoma a little bit out of the way, and just if anyone has any questions, we can come back to it. So what's different about follicular lymphoma in stage 1 and some stage 2 lymphomas is that we can treat it quite well with radiotherapy. And so it's the one stage of lymphoma that has that slightly different pathway. But for certain stage 2 lymphomas, where the two different lumps of lymphoma may be far apart and not encompassable by one beam of radiation, then they tend to be treated like stage 3 and 4, which tends to be with what we would say is a systemic treatment for follicular lymphoma. And these are our current choices for the first treatments of follicular lymphoma. We get to choose from one of each of these buckets when we discuss treatments with our patients. We choose a CD20 antibody. And for those choices in Australia, we have rituximab, which we've had for now nearly 20 years, and obinutuzumab. There are others as well that we don't have easy access to in Australia, but those two are the mainstays and with the most proven track record. Then we have a chemotherapy bucket to choose from. There are others, but these are the three that are the most proven and then also most commonly used, certainly in Australia. They are, and I'll expand on these in a moment. CVP, where as you know, each letter is a different chemotherapy, and the P is prednisone for the steroids. We have bendamustine, and only a single chemotherapy agent is needed in that selection. Or we have CHOP, where you have 3 different chemotherapy agents, C, H, and O, and then the prednisone or the steroids. And then we come to the choice of maintenance. By and large, we do recommend maintenance with the antibody for 2 years. There may be reasons why patients don't have maintenance, and there may be patients that start on maintenance but don't necessarily finish it. And that essentially they are the selections that we make. And it used to be that we didn't have that choice between different CD20 antibodies. We had rituximab and we just had the one. There've been a number of attempts to improve upon rituximab, and obinutuzumab is one of those better attempts. Rituximab had also had this, I'd call it a Y shape. It's a bit of a stretch to call this a Y. Rituximab is the same shape, but it's two little ears up the top here. Actually, what came from some mouse proteins, and obinutuzumab is engineered. We call it a fully humanized antibody. So they've re-engineered some of those molecules. It appears to be more potent in killing the B lymphoma cells, and so can allow more people to enter into a remission, and that remission can last for longer. All good things. It does mean that we get more infusion reactions more commonly. That is, when you're sitting in the chair having the obinutuzumab, more fevers, more episodes of fast heart rate or low blood pressure, which we can generally manage. Neutropenia or low white blood cells are more common, and then after that, infections are more common when we use obinutuzumab compared with when we use rituximab. So that comes into our decision making. So the chemotherapy choice, we have to remember that the V component has some nerve toxicity side effects. The P for the prednisone has steroid-related side effects. The CVP in general has the least side effects of these three choices, but also the lowest rates of lymphoma response. And so we have reasons for choosing the CVP. We often describe it as being gentle. It's a description that only a doctor would say to their patient when the doctor's not the one receiving the chemotherapy. But in the scheme of these three chemotherapies, I'd say that still remains true. Bendamustine has a moderate risk of infection, and CHOP, we would say, probably has also a moderate risk of infection, but is probably all on the more intensive side of chemotherapies. The H ingredient, doxorubicin, can potentially have toxic effects on heart muscle. The O is different letter, but it's the same ingredient as the V and has that nerve toxicity side effect. And there is also the prednisone and steroid side effects that we have to be careful of. And CHOP of these three is the one that does invariably cause hair loss, which can happen with the other treatments, but much less commonly so. So to summarize how I make some of these decisions, it doesn't include every scenario, but I consider obinutuzumab combined with bendamustine as a good choice in a patient who desire treatment that gives them the chance of a really long remission, but also they have to be fit and they have to take infection prevention medication all the way during their treatment and for 6 to 12 months after treatment to protect against pneumocystis, pneumonia, and shingles. It avoids us needing to use high dose of steroids, so that can be really good in people with diabetes or other reasons why high dose steroids are really difficult. A choice of using the rituximab antibody with bendamustine is a slightly less potent antibody, and a good choice again because of less infusion reactions and also less infections. We can use this really comfortably in most cases in the older age groups. CHOP is a really proven traditional choice, and we also gives a high rates of remission. It's a good choice if we suspect that the follicular lymphoma may have any areas of transformation to a higher grade lymphoma, because it's also our treatment for high grade aggressive lymphomas. RCVP, potentially for a more frail patient, but someone who still has lymphoma symptoms that may still desire to have some treatment. So I thought I'd share with you some case studies that are fairly general. So first is a 67-year-old male referred for treatment from another haematologist, and who had stage 4 follicular lymphoma, including bone marrow involvement. And he had appropriately been on a period of watching and waiting prior to starting treatment. And but during that period, he then developed a large enlargement of the lymph node mass near his right kidney, which was causing obstruction of the urine outflow. And his blood tests had shown a marked reduction in his kidney function down to 30% of normal. He was admitted to hospital for an urgent workup and to start treatment. He was otherwise feeling quite well. He didn't have any B symptoms and he didn't have any pain. He did to some degree wonder what we were fussing over by bringing him into hospital. We rebiopsied the lymphoma mass and were able to confirm that it was still follicular lymphoma and there were no areas of transformation. But because that lymphoma mass was deep in his body next to the kidney, we certainly couldn't have a surgical biopsy. So this was a core needle biopsy. And we repeated his PET scan. He had this stage 4 disease that we already knew about, but it did pick up some unusual involvement around lymphoma cells in the lining of the heart, the pericardium, inside the thyroid gland, which is an unusual location. And this suggested to us the possibility of a more aggressive disease, even though we hadn't proven it on the biopsy. Just the locations made us suspicious. When I say we, I mean in our MDT, our multidisciplinary team meeting. So that's a meeting where hematologists in our unit, somewhere between 4 and 8 of us, plus a radiologist, a radiation oncologist, a surgeon, nurses, and a PET specialist, discuss all of our new cases of hematological malignancies and make sure that we've considered all elements of the diagnosis and the treatment planning. And it's really certainly our rule, and I think it's become much more common, that all lymphoma cases are discussed at an MDT to make sure the planning of treatment's holistic. And it's a good thing to ask your hematologist if your case has been discussed at an MDT. The patient's goal is to have the most effective therapy, to get the longest remission. We settled on a combination of obinutuzumab plus CHOP, obinutuzumab being the more potent antibody, and CHOP because we were worried about these atypical locations of the lymphoma cells. So we used that chemotherapy in case there were some of the lymphoma cells that had become more aggressive. After 6 cycles, he entered a complete response. His kidney function had improved markedly, but it was not back down to normal, about 70% of normal. He's currently still undergoing maintenance. Obinutuzumab is doing really well and hasn't had any bacterial infections. He was very comprehensively COVID vaccinated, but because of the times, it had 2 COVID vaccines prior to starting treatment, and has had another 2 since then. We administered him Evusheld, which is the antibody that was somewhat protective against the Delta variant of COVID. And in 2022, actually, just last year, he did have a COVID infection. Thankfully, it was mild. So from this case, the main sort of lessons are that any sign of organ damage to the due to lymphoma requires urgent treatment. Jump on that quickly. That was with respect to his kidney function. And secondly, that vaccination has been a key factor in helping to keep our lymphoma patients safe during COVID. And ideally, we would have our patients vaccinated fully before starting lymphoma treatment, because the CD20 antibody, as well as chemotherapy, prevents your immune system from responding to the vaccine, because it is the B cells in your body that respond and create the protective antibodies, and our treatments are unfortunately not only affecting and killing lymphoma B cells, but they are also affecting our normal B cells, so vaccines don't work as well. At the end of lymphoma treatments, we would usually, I'd say more than often, we would usually repeat all of the COVID vaccinations from the beginning, because because the effect of the prior COVID vaccinations may have been eradicated during the treatment. Okay. And certainly all patients who are having lymphoma treatment are eligible for treatment with the antiviral Paxlovid, and it does reduce the chance of COVID infection becoming a severe infection. Should I stop there and just see if there's any questions that come up that that I might answer now, just to partly just break up the talk, and I'll just keep an eye on the time as well. It's halfway through.
There's quite a lot of questions that have come through, Nicole. We might pick some that are, yeah.
I've got them up here. Oh, it's a great transformation. I'll come to that. I've got a slide on that. 10 years since diagnosis. Only ever had CT scans with contrast, no PET scans. Oh, yes, that's a great question about the timing of doing a PET scan. So it's most relevant to do a PET scan just at the time when you're about to start treatment. So if you've actually had to watch and wait and you haven't been treated and your symptoms are stable, then that's absolutely correct practice. You don't have to jump to do a PET scan. But when we look at how you respond to treatment, we do use the PET scan before treatment and then at the end of treatment to measure response. So for those people who are being observed, the right time to do a PET is just at the time when you may have developed symptoms and may be needing treatment, and that'll be the PET scan. That'll be the comparison that we look at when you finish treatment. So yeah, it's quite okay to have only had PET CT scans if you haven't actually had treatment. Does stage 1 always present in the neck or armpit? No, it doesn't. And a stomach lymphoma is a common place to have stage 1 involvement. It's not necessarily follicular lymphoma. It might be another one called gastric marginal zone, but also stage 1 could be in the groin. So yeah. Hereditary factors, and I haven't touched on this in the talk. So mostly we say we describe lymphoma as something that's not doesn't have as strong a hereditary basis as some other cancers, but there absolutely are families that will have a cluster of lymphoma, and so in the general population, if one person is diagnosed with lymphoma, we don't generally advise. It's not a strong enough genetic effect where we would advise other family members to go and be screened or have tests. So that differentiates it from something like breast cancer. But then you will uncommonly find some families in which lymphoma will cluster. So I do have some family members, some people who are well without lymphoma, who have 2 or 3 other members of their family who do like to come and just see me once in a while to have a blood test and an examination because of a strong family history within their own family. And I think that's fine. I do not like to go and do lots of scans for them, because if they are well and have no symptoms, their blood tests are okay, then doing lots of scans is not necessarily helpful. But yes, it's good to recognize that some families do have that cluster. All right. I'm going to come back to some of the others, and just so I don't run out of time as well, but thank you for asking all of those. Case 2 is a 72-year-old lady living independently. She did have a cardiac history, which was mild, and some mild chronic kidney disease. So she did have some other medical illnesses that are not uncommon at her age. She was diagnosed by a colleague of mine and stage 3 follicular lymphoma, and had some enlarged lymph nodes and also anemia. She's found to have had a past exposure to hepatitis B when on the routine screening that we do. And the recommendation for her was to be treated with rituximab chemotherapy with a CVP. And I wasn't looking after this lady at the time, but she certainly sort of felt to have a level of frailty and probably be has some, and that she may have some difficulties having side effects from the CHOP because of her heart history, and bendamustine because she was although she was living independently, she did have some frailty. She was prescribed an antiviral to keep the hepatitis dormant, and then during the chemotherapy towards the end, she did actually have quite a bad fall at home around in the bathroom. When I just started to take over care, I think I'd come back from maternity leave, and at that point, and I met her just after she'd had this fall, and I think it was probably a combination of some atypical nerve damage in her feet that had caused some imbalance, and maybe also some damage to the nerves that regulated her blood pressure, causing a lowering of the blood pressure on standing. We call it postural low blood pressure, so that when she stood up, she was more likely to get dizzy and fall over. She was worried about some troublesome swelling in the feet and ankles, and I thought that may well have been a side effect of the prednisone, and loss of mobility. And I just remember now that one of the things that she said was she had found it difficult to get up out of a low chair or off the toilet seat, and that can happen when the large muscles in your thighs get weak, and that can be a side effect of the prednisone. So when she completed her last cycle of chemotherapy, we took out the V in the last cycle because of the effect that has on the nerves, and I think I reduced her steroid dose as well. Then towards the end of the treatment, she started to report the more typical numbness and burning in the toes that we do more commonly associate with nerve damage, but she hadn't described those really typical symptoms earlier. And so she's still in remission now after 3 years of what we call gentle treatment. So that was a really good choice in terms of keeping her lymphoma under control. The burning in her feet just actually continued to be a problem, and she just started a trial of nerve pain medication called pregabalin or Lyrica, and a very small dose has actually helped make some improvements in that. She still sees a cardiologist and kidney specialist, and she still has some swollen ankles. So in retrospect, some of the swollen ankles were not actually probably due to a side effect of the chemotherapy, and probably were just due to a combination of her heart and kidney disease. So I think that we always need to remind that so-called gentle chemotherapy still has some side effects, and vincristine is one that we've got to look out for. It can actually cause constipation by affecting the nerves that supply the muscles that squeeze our gut contents down. It can cause low blood pressure on standing because it affects what we call the autonomic nerves. They're the nerves that supply our arteries. And then it can cause the more typical numbness and tingling in the feet, in the fingers and toes. And that's what we're generally, trained, and the nurses will ask our patients every time they have chemotherapy, you've got any numbness or tingling in the toes. So that one we tend to pick up. But then there's these other nerves that we call that control proprioception. That's what allows you to stand up still when you close your eyes. And if those nerves are affected, and it's not the most common effect of this chemotherapy, it feels like you're standing on a big cushy pillow with your eyes closed, and you've lost that good sense of balance, and it can cause people to fall over. So we've got to take care. Maintenance. Once you finish 6 cycles of chemotherapy, you take a big breath, and then your haematologist reminds you that they've also recommended 2 years of maintenance. The good news is that the maintenance with the antibody obviously is generally much, much lower on side effects than the chemotherapy. And then the bad news is you're still coming back to the infusion unit. Hopefully you get getting a little bit more of normality back to life. Maintenance infusions are generally almost always recommend, and there's a couple of just chemotherapy combinations where they just seem to not be needed, like with bendamustine. But in general, it improves the duration of the response, and so it can lengthen the time that you spend in remission. But we don't have evidence that giving the antibody maintenance actually lengthens your duration of life. But it probably does it probably does delay needing another lot of lymphoma treatment. So people will have a different philosophy about, they might have their own philosophy about whether or not they want maintenance. If someone says, no, I would really like to be lymphoma free for as long as possible, I don't want to think about after my treatment, I want the longest period possible of not thinking about more treatment. And they say, well, that's what maintenance treatment has the possibility of giving us, that it is that 2 years after the chemotherapy. It's possible that not all patients require maintenance. Some people's follicular lymphoma, even before we started to give maintenance, we used to just give 6 cycles of chemotherapy and be done. And there were still some patients whose lymphoma stayed in remission for a long time. And we just, we're doing clinical trials at the moment to see if we can understand and pick which patients do and don't require maintenance, so that we're not over-treating, not under-treating, but trying to personalise the treatment. So some of those trials are still ongoing. And some patients do develop troublesome infections during maintenance and then need to stop their treatment early. And there's some data to suggest that perhaps not all patients need 2 years of maintenance, but generally we encourage people to complete as much as they can unless they get those troublesome side effects. So you can see as my voice becomes a bit uncertain, that's where some of our clinical trials still need to be done to give us more certain answers, so that we can be a little bit more sure when we're answering those questions. This comes back to the previous question about PET scans. So we do a PET scan at the end of treatment to see what the responses to treatment has been. And we do like to have the PET scan at the beginning of treatment for a good comparison. And if the PET scan has become completely negative, that is, it's shown a complete response, it's a really good predictor of a longer period of remission. It doesn't happen in all cases, and so in some cases after treatment, there'll still be some residual shadows of lymphoma on the PET scan, and then we have to make a decision between the haematologist and the patient whether we just go into a period of observation of that residual lymphoma or whether we try to keep treating to get rid of it. And that's a very individualized decision. And someone had put in a question about the brightness, the maximum, that is the brightness of the SUV score. That's the score that it tells us how much glucose has been taken up by the tumour. And there was a question about whether a high score, and I think the score was 10 or 12, whether that might suggest that lymphoma had transformed. So 10 or 12 is a moderately high score. That score alone does not necessarily predict transformation. Obviously, there are some higher scores of SUV and they can go up into the 20s. So yes, a very high score would make us a bit concerned. Also, though, I'll show in later slides that the question about transformation is also one that we answer by seeing whether there are symptoms of transformation, blood tests suggesting transformation. So the scan is one piece of the puzzle. Sometimes we make that decision or the suspicion, we suspect transformation, just putting all of these pieces of the puzzle together. It might be that SUV of a certain number plus the fact that mass may have grown quite quickly, that may make us concerned. Or as I said with my past patient, that the location of the mass may be really atypical for follicular lymphoma, and that might make us worried. So, in a person who had a really big lymphoma mass, like the one I've just shown you, at the end of treatment, it's sometimes not unusual to see that there is still a bit of the lymphoma that's still showing PET positivity, and that it actually in some ways has been a good response to treatment, from a very large mass down to a very small dot, but still that does put that person just having that chance that lymphoma area will regrow and return sooner than if it had become negative. So that point is after someone's just had 6 cycles of chemotherapy, and they actually elect to be just closely monitored. If they need to have a break from chemotherapy, they may make a decision that they want to continue on to some more chemotherapy, and that has to be a really individualized decision with their haematologist. In this case, patient went on to some maintenance, so just onto the antibody, and ultimately that lymphoma did grow back. But 6 months later, in some ways that's allowed that person another 6 months to recover from chemotherapy, because when with this follow-up scan showing the lymphoma is growing, really the more chemotherapy and more treatment is really what will be recommended. So having had that 6 months of recovery is not necessarily a bad thing. I'm just going to move on from those pictures. I'm just going to keep pressing through because I've been a bit slow. Our job, the doctors and nurses looking after you, as well as giving chemotherapy, is to try and prevent the complications of treatment. Infection is the real danger that we want to prevent. We can counsel you on avoiding external infections, but some infections will come from the bacteria that reside within our own bodies. Some chemotherapies require antimicrobials to be taken alongside, and obviously early recognition of infection is really important. I want to give you good advice about managing nutrition, managing sleep and exercise. And if that advice is not volunteered by the team that's looking after you, please ask and seek that advice, because really all centres that treat lymphoma should have someone who can give you dietitian advice, sleep advice and exercise advice. Why do some follicular lymphomas respond differently to treatment? It's a really difficult question to ask. It's about the biology of the lymphoma, but also maybe about the other medical conditions that are going on within the patient. We have scores that score follicular lymphoma and tell us about how active the lymphoma is. We have the FLIPI score, can look for mutations in lymphoma cells. We're not so advanced in having a number of treatments that target the mutations that we can use just yet. But certainly we can use that response on the PET scan to predict what might happen next in someone's lymphoma treatment. And then what should we do when follicular lymphoma returns? Well, we've got to firstly know when to pick it up, either from an enlarging lymph node or B symptoms or abnormal blood tests. We'd repeat the CT and a PET scan, and if possible, we'd repeat a biopsy, because we want to know, is this the same lymphoma type? Has it become something more aggressive? And to answer the question, how do we know when a lymphoma is transformed? It's through a biopsy. Could this potentially be a different cancer? A non-lymphoma cancer is another consideration, especially when that lump is in a different spot. We need to know whether the lymphoma is causing symptoms. So we don't always have to retreat lymphoma immediately at the time when it reappears. Just like after diagnosis, watchful waiting is very reasonable first management. Then also when a lymphoma returns, another period of watchful waiting can be appropriate. One time when we generally don't watch and wait is if the lymphoma returns quickly within 2 years of the first treatment, and because that's a sign that the biology, something within the lymphoma it means that it is a more aggressive type of that follicular lymphoma. And so we generally, if someone's fit enough, recommend some chemotherapy and antibody, collection of stem cells and high-dose chemotherapy with an autologous stem cell transplant. And it's a fairly heavy bundle of treatment. So we certainly hope that the clinical trials and some of the drugs that I'll talk about in a moment can maybe replace that. If the lymphomas returned a bit more slowly, certainly more than 2 years after the first treatment, then we can, if another treatment's required, we can select a different antibody and different chemotherapy, or we can go for targeted therapy and certainly referral for a clinical trial. we do clinical trials at different phases, and because it takes years to develop new medications to the point where they're considered safe and effective enough to be used in the general population. And so if a clinical trial is being talked about with you, one good question to ask is it, what phase of trial is it? Is it a phase 1 trial where this is the first time this treatment or combination of treatments being used in a human? Is this a phase 2 trial where the safety is being tested in phase 1, and now we're looking at the effectiveness in a group of people? Usually a phase 2 is somewhere between 50 and 100 people, or a few more than that. Or is it a phase 3 trial when the first 2 phases have been stepped through successfully, and now we're looking at usually a phase 3 is where we compare the new treatment to the existing treatment, and in that what we call the randomization, where you have 2 groups and flip a coin as to which group you may be treated in. But that's where we get our most assured evidence that a new treatment is better than an existing treatment. So this development timeline takes many years. And back to this slide about the different treatments. Here we go. I'm going to go a little bit past the cartoon and just show you some names. I'm not going to show you the trial names because even I get overwhelmed with how many different all the specificities of the trial. The first one I have actually is not in clinical trial. This is an approved treatment in Australia as well. It's available, idelalisib. It's this tablet up here, and although it's approved and available, I rarely use it personally in follicular lymphoma patients. It's got some challenging side effects like fatigue, nausea, and loss of appetite. But it was developed, earlier on, and so it's been made available. And sometimes it is something that we that can help. It can help bring follicular lymphoma under control. The ones that follow here are not sort of currently funded in Australia, but there are various sort of clinical trials where they are available from time to time. Lenalidomide is this tablet here, so a tablet plus a rituximab infusion, and that's got good activity in follicular lymphoma. Lenalidomide is really well tolerated as a tablet, and the rituximab as an infusion is something that's very familiar to everyone. Tazemetostat is an intravenous infusion targeting DNA regulation, and that's got good activity in follicular lymphoma. And a number of Australian sites have had trials of this in the past. A newer monoclonal antibody, not targeting CD19 but targeting CD20, is called tafasitamab, and it seems to have quite good activity as well. And then a whole new class of monoclonal antibodies are these antibodies called bispecific antibodies. Traditional antibodies had that Y shape, and what that Y shape did was that the 2 short arms of the Y attached onto the lymphoma cell and caused the lymphoma cell to disintegrate and die. But what these bispecific antibodies do is that they've got 2 arms that connect to 2 different cells and draw 2 different cells close together. So in this case, they'll draw your own T cell, which is labelled with the CD3, close to the lymphoma cell, which is labelled with the CD20. And T cells are our killer cells, part of our immune system. And the antibody itself helps to make the lymphoma cell die, but also your body's own T cells will actually also help to recognise the lymphoma cell as a cancer cell and kill it. So what an amazing technology. It's been developed over a number of years. We've used it, and it's in acute leukemia for a number of years, a different design of antibody, and now the different agents have been used that are more appropriate, that work better in follicular lymphoma cells. So mosunetuzumab is one that was presented at the American conference in December, and a number of papers on this, and it's showing some really good benefits. It's used alone, not with chemotherapy. It's got some inflammatory side effects, so at the moment you need to come into hospital at the beginning to be observed. And then there are more and more studies of CAR T cell therapy, which is when we extract T cells, your own T cells, then train them to recognize the lymphoma cells, grow them up inside the laboratory, and then return them into your body to go and fight those lymphoma cells. An incredible technology that was pioneered in the University of Pennsylvania and is now really applied all over the world to many different lymphomas, leukemias, and other cancers. It's a highly intensive, like technologically intensive treatment, so it's it will take a while for it to be applied in all parts of the world, and certainly it's not available widely for follicular lymphoma yet in Australia. It has been approved for aggressive lymphomas in Australia. That's where the clinical trials, that's the disease that the clinical trials were done in first, and so it's promising that if the results continue to be as good as they are promising in follicular lymphoma, then we just have to write those letters of submission to the government to seek funding for that program. But look, at the moment, it does have these CAR T cells, like bispecific antibodies, have some fairly serious side effects, and so it's not the treatment that we want to use for the first treatment in follicular lymphoma. Certainly not with this generation of CAR T. It can cause fever, water in the lungs, fast heart rates to the degree where intensive care is needed to support the patients, and it can cause some severe neurological side effects like confusion and coma. But as in future generations of CAR T develop, some of those side effects, I'm sure, are already becoming less of a problem with just changes in that technology. It won't be a treatment that every patient can necessarily have. From some patients that we struggle to collect enough T cells to make this product, so we will still have to rely on some of our other standard treatments. So transformation over a lifetime risk. The risk of this happening, it may be just under 10%. We suspect that if there's a sudden onset of B symptoms, so follicular lymphoma itself can cause B symptoms, but if someone develops a lot of B symptoms in a short period of time, then we may just have that ping of suspicion to investigate for transformation. If blood tests indicate rapid lymphoma growth in the blood, that would be a high marker called lactate dehydrogenase. We might think, oh, we need to do a scan and perhaps a biopsy. Or if one lymph node has rapidly increased in size, we think, oh, maybe a transformation event has happened in that lymph node. We have to scan that lymph node and see if we can get a biopsy of it, and if possible, a really good size biopsy, because transformation doesn't necessarily happen across the whole part of the lymph node. Treatment has to be with chemotherapy and autologous stem cell transplantation in general. I don't think I have enough time for my third case, which is okay. And so I wanted to finish on what to discuss with your treating specialist. I'll leave this up because you can read through that while I read through some questions, and maybe Lisa's prioritize some questions while I leave that slide up. Are there any, Lisa, that you might pick out, or shall I go through?
I think we had a couple that we just wanted to ask. Like, so you were touching on some of the new drugs that were coming through, and they are on clinical trials. How would you recommend our patients that are in other areas that haven't been recommended a clinical trial can access these trials? How can we improve the access for these guys that want to be able to get onto a clinical trial for one of these drugs?
Yeah. So look, not all clinical trials will be necessarily appropriate for all patients. So it does need to be something discussed with our haematologist, with your treating haematologist. But if you feel that conversation is not not sort of progressing, you can certainly ask, or, you know, my patients encourage them to ask a second opinion if they want to from another hematologist. Have no issue with that. And likewise, we're asked to give second opinions as well. So that is okay. Your hematologist ideally should have a mobile phone application on their phone called the Clin Trial Refer app, and we can sit in clinic and we can scan all the clinical trials that are relevant to your lymphoma while we sit with you in the clinic. And I've just got to get over the embarrassment where I feel like I'm doing my research in front of the patient, because I say to my patients, oh yeah, I don't expect to know every trial that's going on in Sydney, and it would be dangerous for me to assume that I know every trial, because one might have come on in the last minute, in the last day, and if I don't look, I might have missed it. So we've gotten over that, you know, any hesitation of looking it up in front of you, and it's, you know, and that's what I would hope my colleagues are doing as well. Sometimes we see people with consideration for clinical trial, and we have to tell them that it's not the right trial for them. And sometimes it might be because of a safety issue, that it might not be safe for them, or for another reason. So, yeah.
And what about compassionate access? Can you just explain that a little bit to some patients who may not have heard of that or before?
That's a tricky one that hematologists struggle with as well. Look, there are some drugs that drug companies will make available to patients, and they'll either cover the cost or they'll share the cost before those drugs are made reimbursed in the pharmaceutical benefit scheme. It can be difficult even for the hematologist to figure out what's available on compassionate access, but we have a network where we just basically ask our colleagues, and so it's worth asking the question of what might be available on compassionate access.
Absolutely. We do have quite a lot of questions. Some of them are a little bit personal, so we might skip over some of those more personal ones. I think you've touched a lot on the treatment side of the follicular lymphoma, but as we know, there's a lot of patients who are on that watch and wait before actually having treatment. Do you make a plan with your patients, or do you recommend that your patients have a plan as if they're experiencing a symptom or an increase in symptom, do they get in contact with you? Like, what do you recommend for these patients under watch and wait?
Yes. So in the watch and wait period, I give my patients a list of usually some information, either our follicular lymphoma booklet from one of the different support foundations, Lymphoma Australia or Leukemia Foundation. I'll outline to them the symptoms, and I'm usually in contact. They usually come into a clinic appointment with me every 3 months, and so I say that within those 3 months, obviously, if they have any symptoms, they generally actually call through to my secretary. Every hematologist will have a different sort of practice of who the contact person is, and obviously their GP is their other first port of call as well, and GPs will often be the ones to refer patients in if they're worried.
That's it. I always tell them to try and have that conversation with their doctor as to what they think, what they are looking out for if something does come up, and when to get in contact. So that's good. There are so many questions. I'm so sorry. There's
another thing I forgot to mention was that we've finished writing the optimal care pathways for a number of different lymphoma types, and follicular lymphoma was included in the low-grade lymphoma optimal care pathway. So this is a document that's it's available for patients to read and for doctors to read, and it's designed for patients and doctors to understand what are the basic tests for different kinds of cancers, to understand if you're getting those basic tests, if you're getting the right sort of tests, or whether you need to ask, well, why haven't I had that test? And so it's a bit of a reference guide both for doctors and patients. Optimal care pathway. So it's an initiative from the federal government. So you can see that it's not going to give you specific advice, but it's just going to tell you whether you're on the right track.
Of course. There's one here that says, once in remission, what would be a reasonable amount of time to have regular CT or PET scans? Maybe yearly?
So in follicular lymphoma, if you're in a complete response on the PET scan, then our follow-up is really what we call clinical follow-up. It's coming to the clinic for an examination, the haematologist asking you about your symptoms and having a blood test. And the scan's reserved for if and when you exhibit a symptom. And only just because if I do a scan on the clock of 1 year or 2 years, I certainly can't be guaranteed we're going to see anything. But then if you come back 3 months later and have a symptom, and I'll repeat that scan, and if that pattern repeats itself often over the course of your follow-up, a person may well end up with, twice as many scans as they otherwise would. It will, over a lifetime increase your radiation risk, and so we don't usually scan to the clock. There are exceptions to the rules, and certainly people who, for whatever reason, can't communicate their symptoms very well, we may rely on a scan. But yeah, we do clinical follow-up.
There are far too many questions to answer, guys, so I'm really sorry. But if you do have some, you can always call the nurse line as well if you want some of those answers. There's just one that's, I suppose, a bit of a hard one for you to answer, but it says that when I was first diagnosed back in 2014, my then haematologist believed that within 10 years, I'd have a 60% chance of relapse, which he was right, but also that we'd be very close to a cure. How are things looking in that regard, do you feel?
And so with follicular lymphoma, aside from follicular lymphoma that's stage 1 or stage 2, we still don't feel we have a cure for follicular lymphoma. We do have people who can stay in remission for a very long time and are in their 10, 15, 20 years of remission, but we don't have that confidence to say that they're cured. So we do use that word remission to mean that there is still that possibility that the lymphoma may return. So those patients are really in sort of a lifelong friendship, their relationship with their haematologist.
Yeah.
The remissions are getting longer and longer.
I suppose that's a great sign. I wish we could always have a cure. That's, I suppose, what we're always aiming for, isn't it?
Watch and wait forever. That feeling that you get when you're about to go to your haematologist for a checkup, and everyone tells me that at least for a few nights or sometimes for a week before they can't sleep because they know that the checkup's coming. I think that certainly that something that try to talk with patients is that a lot of patients go through that feeling of feeling anxious that the lymphoma is going to return, and they feel it every single day. And I say that then changes to then it tends to go to the side of your mind a little bit, and then you get that feeling of anxiousness and nervousness maybe for a few weeks before the next appointment. And then not everyone gets to this point, but a lot of people will get to that point where they've managed to put it to the side so that they think about it in the few days leading up to their appointment. And I think it's a very normal process to go through. Of course, you're going to feel anxious about the lymphoma returning, but the longer and longer since your treatment, the more likely it is that that remission will actually last. And why do I say that? It's just that first 2 years is that time where the more aggressive lymphomas do tend to return, and then after that a lot of the other lymphomas are really, really proving themselves to be of the more indolent type.
Okay, that's great. It's good for people to know that too. There's one here that's been flagged. So just wondering if you know why hot MabThera is not offered as a treatment for follicular when the trials were quite successful.
Yeah, radio-labeled MabThera. So we used to get MabThera and then put a radiation sort of molecule on it. And I remember that from my registrar years. I think ultimately the development went into more potent antibodies like the obinutuzumab. partly because actually delivering radiolabeled rituximab, you had to have this whole infrastructure of the radiation proof rooms, and you had to getting the radiolabeled Mabthera around. It was hard to deliver, and therefore, what if you live out in the country? What if you live out in just out in Orange or somewhere? Those centres wouldn't probably be able to deliver that. So the research went to more potent antibodies that weren't radiolabeled, and then you can ship them around. So I think those are better treatments because you can apply them everywhere geographically.
Just major centres. Someone's just asked, so why 2 years? Maintenance after this, is it possible, available, or recommended?
No, it's not recommended. The trials are not interested. I guess my higher level lymphoma experts in generally, or nationally, and in Australia and elsewhere, we're not feeling that more than 2 years is going to give any benefit. I know that there were trials in 3 years, and so I don't think that showed any extra benefit. A lot of these things are an estimation, so that's why I said that some people seem to do just as well with like 1.5 years, but we don't have the trials to necessarily back that up. But yeah.
There's one here about avoiding all glucose in a diet. It's something that we get asked about a lot. Is there a specific diet, particularly sugar, glucose in diet? Should patients be avoiding this if they have follicular?
There's no reason to avoid sugar in the diet. And I always feel I need to explain that when I explain what a PET scan is, because when you're telling people that the lymphoma is taking up the glucose, it does not mean it's feeding on the glucose. Every cell in your body needs glucose. It's just the source of energy for the cellular mechanisms. You can't starve the lymphoma without starving yourself. Including, remember how bright the brain was? And so your brain really needs that sugar as well. And it's not the sugar necessarily, it's the way you eat it. It's our body is changing our carbohydrates that we eat into sugars. And so you can't starve your body of those nutrients. That's why lymphoma, I think, cancers are that clever, because they feed off some of the same energy that we just need. Diet, a good mix of protein, carbohydrates, and fruit and vegetables for protein, and protein and all the vitamins and minerals. And then it's very uncommon to need supplements. Really only need supplements if you're not able to eat for a couple of weeks at a time. Protein's important, especially if you're on a chemotherapy regimen with steroids, because steroids make it really difficult for you to keep muscle on. And so you have to think like not like a bodybuilder, but pay attention to the protein in your diet. Protein shakes are good.
It's interesting you touched on the supplements there. I suppose it's really important to point out to patients that supplements aren't bad, but sometimes if you are on a supplement, it's good to discuss that with your doctor, just in case there are some interactions between something that you're taking. So we're not against you taking them, but it's always just advised that you discuss what you are taking with the doctor, because it's so important that if you are on something that is interacting, that you're not taking it.
The microbiome.
Are you running out of...
Has anyone asked a question about the microbiome?
No, but go for it. It's probably a very good thing to mention as well while you're on it.
So the good bacteria in your gut are really important. We don't really know yet how important they are, but they are important to avoiding, I think, diarrhea that happens in chemotherapy, and obviously sometimes we have to prescribe antibiotics, and that will just completely get rid of your good bacteria. And your good bacteria come from us eating like a balanced meal, because the good bacteria comes from you eating enough fiber and enough vegetables, and that basically feeds the good bacteria. So we want you to eat that balanced diet, not necessarily go too much on supplements. Certainly don't be too restrictive. Don't just start cutting whole food groups out, because all those food groups will help to feed your healthy gut biome as well.
Right. And do you recommend patients take a gut supplement? So a lot of patients ring up asking if they should be taking like Inner Health Plus or something. What's your recommendation for these patients?
I can't wait for someone to do a good clinical trial where they tell the doctors which ones to recommend. We used to be a bit nervous about people taking a probiotic because it's got bacteria in it while you're having chemotherapy. I think that their probiotics are really low risk. I don't think they're going to give you an infection, but we just don't have enough information to know what to recommend. So I think that discuss it with your haematologist. Can I say that I just recommended one of my patients today to take a probiotic? I just think it's, you've got, like, I prefer to have that discussion with the patient, because there might be reasons why your haematologist may not think it's a good idea. Yeah.
Great. And again, like you say, discuss it with your doctor as to what your personal circumstance is.
Yeah.
Someone has asked, what impact does repeated vax have on the capacity of our innate immune system to recover and rebuild itself, especially given that we don't respond well to the vax?
That's such a deep question.
Yeah.
Look, if we give a vaccine and you're having chemotherapy and you don't respond, you don't create the protective antibodies, I don't think we've got any evidence that the vaccine is going to impair our immune system from recovering or fighting back. It will sort of go in like a undetonated, little shell. It'll just sort of vaccine will plop into your body, and it'll just your immune system will go, I'm just too tired to deal with that vaccine, and then the proteins in that vaccine will just degrade away. So I think that that's sort of what's happening when you're having chemotherapy. Your immune system just cannot deal with the fact the vaccine is there, and the vaccine does just sort of poofs out in a cloud. I don't think it has a negative impact. But I do think that because you can get a sore arm after a vaccine and it's going for another injection, during chemotherapy is not a great time to go and have your vaccines, because they won't work. And I just try and tell my patients, just reserve it for later. Don't go and have another needle right now. Yeah.
I love the way you just described that. I don't think I've ever heard it explained that way for patients. So it's a really good way for them to understand what it actually does in the body. Someone's asked, what dates are used to determine relapse? Either the first date of treatment or the date of the last treatment. I suppose that's probably quite a
relevant, because it's a good. Well, if we take aside maintenance, because but just think about the 6 cycles, because it's like almost 6 months difference in the date. All the trials will talk about the time from starting treatment. Okay, that's always the time point that they use, the date of starting treatment. But when I'm sort of seeing my patients in clinic, I'll often, when they finish treatment, I'll say to them, it's been 6 months since you finished treatment. It's been 12 months since you finished treatment, because I like that. To me, is just an important landmark. But in terms of translating that into relating that back to the trials and saying, well, therefore that means we're doing really well, and talking about it more formally, you take it back to when the treatment started. Yeah.
Okay, perfect. I think this question came up when you were discussing the different treatment types, but does bendamustine have a greater nerve toxicity than that to vincristine?
Bendamustine does not have any specific nerve toxicity.
I think that was just a question from one of the patients, and I think that's quite a lot of questions. But like I've said, guys, if you would like to have any of your specific questions, you can ring our nurse line. It's all over our website, 1-800-953-081. And Nicole, we really thank you for your time today. It was just amazing for you to explain everything from beginning to end, including clinical trials, and then answer so many of these patients' questions. I think we had over 100 people, and we have a lot of follicular patients who really appreciate what the updates and what's coming through. So thank you so much for your time today. We really appreciate it.
You're welcome. Thank you very much.
Thank you, everybody.
Thank you.
Okay, great. Thanks. Bye.